I'm feeling slightly nervous because there have been two heavily intellectual, rigorous arguments about Roman law and big data sets, and I'm coming to you as a clinician working in a field where trust, a big topic we've been hearing about, is paramount, and really trying to think a little bit about a specialty where data has been very, very carefully controlled. The idea of data sharing has been incredibly angst-provoking amongst both service users and their carers, and actually to think a little bit about how we approach this, because both previous speakers have talked about these fabulous data sets. I mean, you've got that wonderful box with God knows what in it, but a doctor and a patient have somewhere along the line had to have the time and the energy to put that in. So I want to bring us back to the consulting room and think about this in the context particularly of HIV, where I think at the beginning I would say if we can get it to work for HIV, we can probably get it to work for most other things. So we could use HIV as quite a good canary, perhaps, for some of the systems and to see what happens. One other point that I think is important to make at this stage is that we are absolutely in the middle of a tsunami of change, particularly in the world of HIV and STIs. And for the first time, although I take your point, we're going to see some interesting positives from any qualified as opposed to any willing provider. In the world in which I work, we are now beginning to see clinical services that are going to be developed by local authorities. And so what were data sets that were held in NHS systems may actually now be held in other systems in other places and may not be as accessible, and we need to think about that. Now, again, thinking about today, I wanted to bring to your attention another dead epidemiologist and public health physician called Jonathan, who is Jonathan Mann. And actually, it was Jonathan Mann, I think, who has really done a huge amount in helping us to understand HIV and this epidemic. And I want to bring to your attention this particular quote, because he talked about three epidemics. He talked about the epidemic of people acquiring HIV in the first place and essentially a long silent period. He then talked about the second epidemic, which was of ill health associated with that. But he talked very strongly of the third epidemic, which is, as he puts it, the social, cultural, economic and political reaction to AIDS. And that is one of the challenges. And actually that is the challenge that remains still today in our world and our clinical world about how we deal with this, because it is this whole epidemic of stigma that colours what people want to do with their data. It colours whether people trust the system or not, and that actually I think is terribly important. And Jonathan Mann really brought that to everybody's attention in that speech when he set up the UN AIDS back in 1987. Now, the other thing you need to know about HIV and STIs, and I'm sure many of you probably do already, is that there are, over and above statutory legislation, there is secondary legislation about what data can and can't be shared, even within clinical teams. And the old regulations, the Venereal Diseases Regulations 1974 and the PCT NHS Sexually Transmitted Diseases Regulations 2000, allowed for completely separate records and completely separate methods of storing clinical data. And interestingly, these have now been revoked, and they died on the 1st of April because they related to organisations that are no longer in existence. So you can't have a law about what you do in a PCT if there isn't a PCT. So the question is, now what do we do? Do we make a new law? Do we say, thank goodness that's over, it's all okay, and we put all our HIV and STI records into these black boxes, as we've got on the floor there, or is there going to be something new? And as we understand it at the moment, the Health and Social Care Information Centre is currently working on a new code of practice, which is going to be informed by Caldecott 2, about what actually the requirements about confidentiality and sharing are going to be. And this is actually very interesting because it is going to apply across all providers. And up to now, the venereal diseases regulations have only applied to NHS. So, for example, if the Terence Higgins Trust runs a testing centre, they've not had to be followed by those particular regulations. Whereas in the brave new world, every care provider will be covered in this particular. And as I understand it, that's going out for consultation when Caldecott is released. So we've got another very interesting piece of work that's going on there. I think there are three major areas that I just want to try and touch on because I think they all play a huge part in just thinking about this and colouring what individual people and their carers and their clinicians do with this data. And I think there's the things we've been hearing about now, the big stuff, the setting the scene, giving direction, planning services, doing the research, the big picture. But then there's something about securing best care and actually how you use these electronic data sets for doing that. And that last bit at the end, which Jonathan touched on, personal safety, the individual person making the decision about whether they put that information about their HIV status in the little envelope, on the spine, on the shared data set, on the one record or not. Because, of course, if it's in the envelope, then it's not going to get into anybody's data set and it's not going to be in your black box, which is going to confound what happens inside the black box. So very quickly, I think we have to also think where we've come from, because what we needed to do in terms of both data collection and how people responded to it have been different across the epidemic. We've had 3 decades of HIV. We've got 3 phases, if you like. We started with crisis management, palliative care, and finding out. And at that point, nobody wanted anything written anywhere. GPs weren't aware. People kept separate little bits, so the GP took letters home and put them in the back of his bookcase or whatever it was. And it was about secrecy as much as about confidentiality. And at that point, a lot of people looked unwell with AIDS, and actually, often people made inferences about what was wrong with people. We got to the second decade where we actually have got drugs now, we have efficacy, we're beginning to control the virus. And so the data, the trials, the big randomized clinical control trials, incredibly important. And what I would suggest to you where we are now is we've got efficacy and we now need effectiveness, because actually even if the drugs work really well in test tubes, if people are scared and don't get tested and don't take them, we have a problem. We're looking at a long-term chronic disease as opposed to managing acutely sick young men who are coming into hospital and dying. We're looking at a diverse population who are getting older. We are looking much more at prevention. And I would suggest to you that because people living with HIV no longer have the identity on their bodies, it's much more about disclosure. You have to actively tell somebody in a way that at the beginning of the epidemic you didn't have to do in quite the same way. So there's a much greater discourse now in our clinics. Shall I tell or shall I not? Because actually people wouldn't know otherwise. So a couple of other things which I just want to tell you about, which actually tells you about the life expectancy here, which actually informs everything. This is clinical data. This is clinical data collected from an observational cohort data set, which we all put our day-to-day clinical data in UK Chic, which has shown us this increase in life expectancy in HIV in the UK. And you can see the different lines. Women live longer than men. The key issue is that if you present late with a low CD4 count, you can lose up to 15 years of life. And that data set has informed the next bit of the discourse, which is we must test more people, we must broaden testing, we must get people into care much earlier, and that is the sort of driver that's going on at the moment. The other very important thing that we have is that we clinicians all send data into the Health Protection Agency, now Public Health England. And I would just like to show you this, and I'm going to come back to this slide again in a minute. This shows us what we know about people with HIV in the UK. So you take 100% of all the people living with HIV in the UK, only 75% of them are diagnosed. So question number 1 for us is, let's look at that gap. What's going on there? Of those who are diagnosed, we are losing a proportion, not that many, but the majority of them are getting into treatment. And of those on treatment, not all of them have got an undetectable viral load. So when you look at the national data set for HIV in this country, it says to you why aren't people testing? Why aren't they getting into care? And if they are in care, why aren't they taking their tablets? And that comes from surveillance, from the public health surveillance set, and those are the sort of clinical questions, if you like, that come out of that for us. Now, this was published last week by the Health Protection Agency, the data sets that are collected, and this is very important because the local authorities are going to need to collect this data as well as the clinics, and there's going to be a new data set coming out, the HARS reporting system, and it's going to be really important. And never mind the research, which is crucial, it's going to inform how clinics get paid. It's going to be the real driver for whether there are enough nurses' salaries coming in. So everybody's going to start having to do it in a much more rigorous way. It's going to colour commissioning, it's going to drive quality, and it's going to continue to do surveillance. And this data tells us how many people are being diagnosed, it tells us where they live, and this is very, very interesting for the localism agenda, because you can see actually the localism agenda is probably very important in HIV, but it will fragment again. These big data sets, these big national data sets, are going to start going down to borough level in London and to county level across England. And it tells us the age, it tells us the sex, and it tells us what's happening over time, all of which inform our clinical practice. And it tells us about quality, and I've shown you some of that on that other graph. And we are, I have to say, doing amongst the best quality outcomes across the resource-rich world. So I bring you back to this because this is based on a big electronic data set, and it informs our clinical practice, and it's the gaps. It isn't necessarily the bars that are telling us the answer, it's the bits between the bars which we need to find out. So let's go down a level, because I'm going to run out of time, just thinking a little bit more. If we've got these clinical systems now, we have electronic patient records, we have EMIS, we have a whole variety of ways of collecting data. How do we share clinical data safely? Well, one big thing that we do know is that doctors don't spot HIV. And if the patient doesn't know they've got it or doesn't choose to tell somebody, then actually a large proportion of people are just undiagnosed. It's just dangerous. And I showed you that graph that late presentation means you die much quicker, and actually doctors don't think about HIV. 25% of a snapshot in the UK in 2010 showed that 25% of patients had at least one missed opportunity for diagnosis. And so one big issue is that there's not enough communication, because HIV is kept perhaps in this silo. So for safe care, these electronic shared clinical databases, never mind anything else, are absolutely crucial. And actually, when it comes to it, they are more secure than paper notes, because you leave your fingerprints all over it when you open the care record. But I hear all the time from an African migrant population living in Hackney who say, I don't want to come into the hospital because my aunt works on the ward and she will look at my notes. But what you have to be able to say is, well, we can see if your aunt has looked in those notes, and actually if she has, she could be disciplined. But we haven't quite got that moving forward yet, and people think, I think, going back to Jonathan's point about trust, that somehow computers are less safe, whereas actually they're more safe if they're used properly. Misdiagnosis is crucially important, not only because people are, it's an opportunity to share the diagnosis that people have got, but the other big issue for the clinicians in the room, the killer molecules in HIV care are the cytochrome P450s, because they have drug-drug interactions. And some of the drugs that induce cytochrome P450 mean that the antiretrovirals get metabolized quicker and you get drug resistance, or they're blocked and you get drug toxicity. So if you are somebody living with HIV and I'm prescribing your antiretrovirals and you haven't told anybody else, we've had one woman recently who's died of complications of diabetes brought on by Cushing's syndrome due to an asthma inhaler taken with a protease inhibitor, and she's dead. And that could have been avoided if we all knew what was going on. And actually we have fabulous electronic databases of drug-drug interactions if we use them. But if you look at the research, a significant number of people living with HIV say that they have experienced discrimination in a healthcare setting, specifically, and that they are worried because it's not the doctor who will breach their confidentiality, but actually the doctor's receptionist goes to church with their mum. And that's when they don't want the stuff on the computer. We've now made some standards. The British HIV Association, we produce standards of care for people living with HIV, and I just pull out two. We've put specifically that we believe that people living with HIV and their care providers must communicate between primary and secondary care, that there must be at least an annual letter, and there must be evidence the patient has a letter. But a piece of research we're going to present at the British HIV Association next week shows that even when the GP has a letter with the drugs on it, they don't put them onto EMIS, they don't copy them in to the electronic database. So we've got a database, there's another database, they're not talking to each other, and it requires the human hand clicking the mouse, and that's another big area where we get incomplete data. We have a big issue still, and this is a study that we did at Homerton. About 1 in 4 women across the UK can expect to be involved in intimate partner violence. It's much more prominent in women with HIV, and about half of the women living with HIV attending our service have experienced intimate partner violence in their lives. And that is often associated with disclosure. So people don't want to tell people what's happening because there is a personal safety issue here. And then coming back to the law to round off is that actually if people don't tell sexual partners now, they are at risk of prosecution under the Offences Against the Person Act 1861, which was never designed for anything to do with any sort of sexually transmitted disease or HIV, but that is the law that is being used. And so we now have a set of responsibilities as clinicians about what people should be able to disclose to sexual partners, what might happen to them if they don't and that person acquires HIV. And there have now been, I think, 14 or 15 convictions and imprisonments of people for reckless transmission. So we as doctors have a duty to advise about that as well as maintaining these aspects of confidentiality. Now, we've taken quite a strong step in our standards, and in standard we put in a standard about data, and we have suggested that it would make much more sense if people living with HIV were managed on their NHS number. And we might then begin to see people with HIV in your black box. And I bet you haven't got a representative sample in that black box right now. But that would then allow for a whole variety of linkages with other NHS services. It would improve audit, research, surveillance, service planning, and we are very strongly recommending this. We are having quite a bit of pushback at the moment from people living with HIV saying, I'm not sure that we're quite ready for that yet. But that is the way we're going, and we feel very strongly about it as we move into any qualified provider, because if you are living with HIV, the only bit of data that's going to stick with you through all that is your NHS number, because you'll have a DOSH number somewhere, you'll have a GU number somewhere, and this actually in terms of clinical risk, and if we can tell patients in terms of trust that this is a bigger clinical risk than the other things that might happen to them, I think it's really important. We've put in a standard 12, is that people with HIV should expect to be informed about opportunities to take part in research, and that people delivering care should actively provide data to surveillance programs, audits, and for research. So we've put this as a basic standard of care for all providers. So in summary, I think my response to what do we do about electronic databases is yes, but. They're central. We are living in a digital world. To assume that we can't have proper digital data is a nonsense. It is going to be central to absolutely everything we do, and the benefits are huge. But still, going back to Jonathan Mann, as long as we have an epidemic of stigma and domestic violence and healthcare discrimination and the secrecy that goes with that, there are some real risks, and they're really relevant, and we have to address those. But I would just come back to the point that if it works for HIV, I would suggest it will probably work for most other things. So we're very happy to be a model, and we'd like to see if we could take this debate forward. So thank you very much for inviting me. John Snow clearly, I think, has left an enormous legacy. It's a huge privilege to be here. I don't know what he'd have made of HIV and the risks and the stigma, but thank you very much for including HIV in today's programme.